So renal pharmacology, first we'll deal with the renal physiology part. As in the last lecture on renin, angiotensin, aldosterone mechanism, I have told you that the renal system or the kidney receives about 1 liter of the cardiac output, right? This 1 liter, from this 1 liter, 400 ml of it goes to your extracellular tissues, and 600 ml enters the glomerulus. Right? Out of this 600, about 20% of it is filtered, right? And that becomes your GFR, which is 120 ml per minute, right? So 10% of 600 is 60, and 20% is another 60, that is 120 ml per minute. So your GFR is 120 ml per minute. So now, as you know, this is the Bowman's capsule, and this is the glomerulus part, right? And there are a number of solutes and solvents and water that is being reabsorbed throughout the entire process of the nephron, right? So what we are going to do is we are going to look at particular segments step by step, and we are going to put diuretics into those and see how the pharmacology acts on these particular segments. So to begin with, the basic solutes, the basic ions that the body wants to reabsorb will be your sodium. Apart from sodium, there is one more ion which the body really wants to absorb, and that is your bicarbonate ion. Right. Now this sodium and bicarbonate ion, if they want to get reabsorbed, they have to enter the cells, right? And then they have to get reabsorbed through the peritubular networks and then go back into the general circulation. So your general circulation begins from here again, and this goes back and joins the general circulation as the renal vein. All right. So that is how the solutes and the other ions are reabsorbed. Now, before we begin to talk about how these ions are getting reabsorbed into the cells, we have to talk about a little about certain transporters that we have on the basal and the lateral sides of these cells. So this is the basal side of a cell, all right? And this is the lateral side. This is the lateral side and this is the basal side. So there are special kind of transporters that we have on these cells, and they are called as sodium, potassium, ATPase transporters. All right. So what they do basically is they will kick 3 sodium out and take 2 potassium in. So when I say they kick 3 sodium out, I mean to say that they reabsorb the sodium into the general circulation. Now, since these transporters or these molecules require the help of ATP, they are termed as sodium potassium ATPase pumps. They will be actively working 24/7 on the basolateral membrane of all the cells that you have. All right. So if you want to, you can put these cells, these transporters, on all the cells, on the big cells that I have drawn. Right. So these red color things that I have drawn, these basically are your sodium potassium ATPase pumps that will kick 3 sodium out and take in 2 potassium. So when we discuss about the different diuretics, we'll be marking them as we go on. For now, we just put up the sodium potassium ATPase pumps. Right. Now, the first step that happens in this process of physiology is a reabsorption of sodium, is that this sodium that you see over here, it gets reabsorbed inside. So sodium goes inside, all right? And this sodium via the sodium potassium ATPase pumps is kicked out of the cell and it is reabsorbed. And in turn, two potassiums come inside the cell. All right. Now this reabsorption of sodium is not that simple. In exchange of sodium, this cell has to kick out one proton. All right. So you can call it as a counter transport. One sodium goes out inside and one proton comes outside. All right. Now, next what happens is, the next step that happens in this physiological process is, as this proton is coming downwards into the proximal convoluted tubule, it meets up the bicarbonate ion. Right. And when it meets up the bicarbonate ion, what happens is there is union of these two ions. The union of these two ions is taken over by or officialized by an enzyme which is present on the luminal side of the nephron, and that is referred to as your carbonic anhydrase enzyme. Right. So what this carbonic anhydrase enzyme does is it will cause the union of sodium of proton and bicarbonate and converts it into H2CO3. H2CO3 is your carbonic acid. So in the presence of carbonic anhydrase, this particular proton and bicarbonate, the bicarbonate is got from your normal reabsorption from the glomerulus, and the proton is achieved from in exchange to the sodium. So this proton combines with bicarbonate and forms carbonic acid in the presence of luminal carbonic anhydrase. Now this carbonic acid which is now formed, what happens to this is the third step here is that this will split. Right. This will split into water, all right, and this water continues downwards, right, and HCO2. Now, since CO2 is a gas, it can freely move inside the cell, right? So CO2 goes inside. Now, once it is inside, what happens is, cells will have water inside, right? So this CO2 will combine with water inside. Now, this combination cannot happen normally. You need a medium for it. And the medium inside that does this is again your carbonic anhydrase. Now, this carbonic anhydrase is not luminal carbonic anhydrase. This carbonic anhydrase is your cytoplasmic carbonic anhydrase, right? So this cytosolic carbonic anhydrase will cause the union of this water which is present inside the cell and the CO2 which has come from the outside, from the lumen inside the cell, and it forms what? It again forms carbonic acid inside. All right. Now this carbonic acid, what happens is, this carbonic acid will now split. Split into what? It will split into the proton, and it will split into again the bicarbonate. All right. Now this bicarbonate is then kicked out of the cell in exchange for, so this bicarbonate goes outside and in exchange you get chloride inside. All right. So what were the two important ions that we wanted to reabsorb? We wanted to reabsorb sodium and we wanted to reabsorb bicarbonate. So sodium got reabsorbed in exchange to proton. This proton combines with the bicarbonate to form carbonic acid in the presence of luminal carbonic anhydrase, and then this carbonic acid splits into carbon dioxide and water. Water goes downward. This CO2 travels inwards and combines with the water present inside the cell in the presence of cytoplasmic carbonic anhydrase enzyme and forms carbonic acid. This carbonic acid now splits into proton and bicarbonate ion. This bicarbonate ion is kicked out of the cell. That means it is reabsorbed in exchange with the chloride ion. All right. So this is how our two main important ions are reabsorbed into the body. Why do we need bicarbonate? We need bicarbonate to maintain the basic pH of the body. All right. So that is the reason why we require bicarbonate. And why do we require sodium? Because sodium, as we have dealt in the earlier chapters of antiarrhythmics, it is the prominent or the main depolarizing ion of all the excitable tissues in our body, right? So that is the reason why we need sodium and bicarbonate. All right. Now let us put pharmacology into this. So how can you do that? We have a group of drugs which are called as, let me write it over in the corner. We have a group of drugs which are called as carbonic anhydrase inhibitors. All right. So one primary example, we'll be talking about the adverse effects, the uses and other drugs of this group in detail in tomorrow's class. But for today, you just remember this particular drug, which is called as acetazolamide. So what this particular drug does is, it will inhibit the, let me take, this will inhibit this particular enzyme. So if it inhibits this particular enzyme, what happens? There is no reabsorption of sodium, because sodium was getting reabsorbed in exchange for proton, which was coming from the carbonic acid being produced from the CO2 that was being formed from the union of proton and bicarbonate ion outside, right? So what happens is sodium doesn't get reabsorbed and bicarbonate doesn't get reabsorbed. All right. So these will travel along the way. All right. Now, the one thing that you have to remember is that around 65 to 70% of sodium gets reabsorbed in this proximal convoluted tubule. All right. And if the sodium doesn't get reabsorbed, there are many other areas where the sodium can get reabsorbed. That is your thick ascending limb of loop of Henle or distal convoluted tubule, or 2 to 3% of sodium is also reabsorbed in the collecting duct. So the excretion of sodium when we utilize carbonic anhydrase inhibitors is very mild, and that is the reason why carbonic anhydrase inhibitors are called mild diuretics. Right. Before we go into the definitions of all of that, I would just like to remind you that wherever sodium is going, water will follow it. All right. And the basic meaning of a diuretic is that it will expel water from the body, right? So natriuresis and diuresis are two words that can be used interchangeably. All right. So if you remove sodium from the body, water will follow and the blood volume will go down. And if the blood volume will go down in a hypertensive patient, his blood pressure will also come down. So what is happening is, since these carbonic anhydrase inhibitors are acting at the level of the luminal carbonic anhydrase enzyme, sodium and bicarbonate are not getting reabsorbed, right? And so they travel along the way, all right, and they get excreted. So when sodium gets excreted, water will follow it. And if water gets excreted from the body, we call it diuresis. And when diuresis happens, the blood volume will fall down. And when blood volume goes down, the BP already comes along with it. All right. But since the reabsorption of sodium is happening at this particular level, at the level of the proximal convoluted tubule, and since we have got other areas also, like the upper thick ascending limb of loop of Henle, we have got the distal convoluted tubule, we have got the collecting duct. The sodium that is excreted because of usage of carbonic anhydrase inhibitors will be very less. So you say that carbonic anhydrase inhibitors are very mild diuretics. All right. So if a patient has got BP around, let's say 160 by 80, so you can give those patients mild diuretics, which are nothing but your carbonic anhydrase inhibitors. All right. So this is about the carbonic anhydrase inhibitors. All right. Now, one thing that I would like to add over here is I would like to take you along to the last part of the nephron, which is called your collecting duct. All right. Collecting duct is also the site where your aldosterone acts. If you remember the renin-angiotensin-aldosterone mechanism, I have told you that a collecting duct has got cells which are called as principal cells. Now, principal cells are the areas where your aldosterone works. So that we'll be talking about when we talk about the potassium sparing diuretics. All right. But for now, I would like to explain a little bit of physiology over here. What happens here is in this particular area, the proximal, the collecting duct, what happens is, as always, this particular, the cells that, that are present here will have sodium potassium ATPase pumps. So these sodium potassium ATPase pumps, what they do is they will kick 3 sodium out and they will kick 3 sodium out and they will take 2 potassium in. All right. Now, this sodium will again go into the general circulation and get reabsorbed. All right, this is the continuous process that is happening every time. 3 sodium getting kicked out of the cell and 2 potassium coming out. So at any given point of time, our body, our cells of the body will be deficient in sodium because sodium will be continuously getting kicked out of the cells and the cells will be rich in potassium. All right. Now, apart from these principal cells or the P cells having these sodium potassium ATPase pumps, they will also have on their luminal side certain ion channels. These ion channels are nothing but your sodium ion channels. All right. So these are your sodium ion channels, and in addition to that, they will also have what? They will also have potassium ion channels. So what happens is when the sodium is traveling along the way, along the thick ascending limb of loop of Henry and the distal convoluted tubule, and it is coming over here at this particular junction. What happens is the sodium, which was not reabsorbed in the PCT because of the action of CA inhibitors, will come over here. So this sodium will get reabsorbed over here. Now, this is not a large amount of sodium that is getting reabsorbed. There is a minimal level of sodium getting reabsorbed because the P cells are allowed to work only this much, only so much. They cannot take it, if it is capable of reabsorbing only 2 to 3% of sodium. If you ask them to reabsorb 70 to 80% of sodium, they cannot do that. All right, they are not capable of it. So what happens is when the sodium is coming here along with the bicarbonate and water, the sodium gets reabsorbed through these sodium ion channels. All right. And by virtue of the sodium potassium ATPase pumps, they get thrown out and into the circulation and they get reabsorbed. So what happens when the 3 sodium are getting pumped out, 2 potassiums are coming in. All right. So this will cause what? This will cause the potassium to be thrown outside by the potassium ion channels. Let's not write 2, just write K plus. So what I'm trying to make a point over here is that whenever you use carbonic anhydrase inhibitors, these carbonic anhydrase inhibitors will cause the excretion of potassium. So carbonic anhydrase inhibitors, the one point that you can write is that they are potassium wasting drugs. Now, if you remember your renal pharmacology in the classes that have been taken in your college, you will remember certain drugs that are called as potassium sparing and some drugs are called as potassium wasting. So carbonic anhydrase inhibitors are referred to as potassium wasting drugs. All right, but let me make a general point over here. All the drugs that act before the level of the distal convoluted tubule, they will all be potassium wasting drugs. And the drugs that act after the level of the distal convoluted tubule will be potassium sparing diuretics. All right. So now another conceptual point that I have to make over here is that when the sodium is getting reabsorbed, right, and the potassium is getting excreted, all right, this area, since it is losing positivity continuously, this area will become highly electronegative. All right, this area will become highly electronegative. All right, and uh, apart from this area getting being highly electronegative, the factor that adds on to it is that there is some amount of chloride also which is getting excreted and coming into this area. So that will add on to the electronegativity. Now, when there is highly this when this area is highly electronegative, what happens is it will attract more of potassium outside. Since potassium is very high inside the cell, this highly electronegative area will attract the highly positive potassium outside, and it will lead to more of potassium being getting excreted. All right. So the point that you have to remember in this particular segment is that there will be increased reabsorption, all right, and there will be increased potassium leakage, all right, and since there is negative chloride and negative bicarbonate, it will attract more of potassium from inside the cells into the lumen, and that will cause more of potassium wasting. That means the potassium getting excreted. And the third thing is, since water is also coming, it will add on to the potassium getting excreted very fast. So there will be a basic flush out of the potassium because of the water and because of the negative ions that are coming because of the application of carbonic anhydrase inhibitors. The potassium ions will be washed out rapidly because a potassium gradient has been developed. All right. So these are the few points that you have to remember with respect to the carbonic anhydrase inhibitors. So let me just sum it up for you again. The two most important ions that we have to reabsorb are your sodium and bicarbonate. So this sodium gets reabsorbed with respect to an exchange of proton. Now this proton combines with the bicarbonate and forms carbonic acid. This carbonic acid splits into carbon dioxide and water in the presence of luminal carbonic anhydrase enzyme. This carbon dioxide is formed, it goes inside because it is a gas and combines with water inside in the presence of cytoplasmic carbonic anhydrase and forms carbonic acid. This carbonic acid splits into proton, which combines with the bicarbonate outside, and this bicarbonate is exchanged in exchange with the chloride. Right. Now, when you apply carbonic anhydrase inhibitors such as acetazolamide, what happens is the sodium and the bicarbonate and the water is not reabsorbed. All right. So what happens is the sodium will enter the last part of the nephron, the bicarbonate will enter the last part of the nephron, and since sodium is going to the last part of the nephron, eventually water will also follow the sodium. Now we have a little mechanism which is overtaken by the P cells, and what these P cells do is they will cause a minimal reabsorption of sodium. And hence, since the positivity is leaving the lumen, this area will become highly electronegative. The first reason is because the positivity is leaving the lumen. The second reason is more and more amount of chloride and bicarbonate ions, which are negative ions, are coming into the lumen. Because of this electronegativity, what happens is it will pull out extra potassium from inside the cell. Because we know that since sodium is getting reabsorbed, the sodium potassium ATPase pumps are pumping into potassium inside. So this cell is rich in potassiums. And you know that ions, they love to come down a concentration gradient. And because there is so much of negativity outside, they will attract the positivity from inside the cell. And so the potassium gets excreted. And since there is water also coming along, what happens is this sodium excretion occurs very fast. There is rapid washout of the potassium ions. So carbonic anhydrase inhibitors are referred to as potassium wasting drugs. All right. So this is the concept related with the carbonic anhydrase inhibitors.